So I think it's now 11 o'clock. So Alex, if you're content, I would like to start the meeting.
Yes, absolutely. I will just start off with just some housekeeping, and then I will hand over to Professor Dayman Johnson, our Vice President International at the Academy of Medical Sciences. So I just wanted to firstly say thank you to everybody for their work over the last 3 days. It's been very much appreciated, and it's good to see so many familiar names joining us for this morning's and afternoon's and evening for some of you your session. I just wanted to introduce the AMS team very briefly. We've got myself and my colleagues Abigail and Vern. They are on hand for any technical issues. So if you are having any technical problems, then please do contact them. You should have their email addresses. I wanted to also just point out that today is going to be chaired by Professor Guy Thwaites, and I will let him introduce himself in a moment after Anne has opened the meeting. There's some technicalities. The mute will be a default function. So today we're doing a separate format to what the last 3 days have been, and we're in webinar. The panelists are the speakers for today, and they will be able to speak verbally. The rest of you will be attendees, and we will be able to allow you to talk during the question and answer, the clarifications, and also the final part where we are going to do a plenary discussion. So that is, if you want to speak, you will need to raise your hand, as you can see on the slide in front of you at the moment, and we will allow you to speak. Alternatively, on this format, you can also do a question and answer where in the chat box, where people will be able to upvote questions or points, and we will use these to prioritize during the question and answer sessions and the plenary discussion. So that is the plan for today. I just wanted to note that it's being recorded and it's also being live streamed across the world. And welcome to the viewers on our own website and also on the Inter-Academy Partnerships website. And I think that is pretty much everything that we're going to cover, that I need to cover from a technical point of view. I will therefore hand over to Anne to officially open, and then it will be Guy who will take you through today's session.
Thank you very much, Alex. Well, first of all, let me welcome everybody from all around the world. It's fantastic to have so many people with us today. And I am welcoming in my capacity as Vice President International of the Academy of Medical Sciences, who has been organising this workshop. And today is actually the culmination, Alex has said, of 3 days of working together with members from across 8 countries around the world on aspects of public health aspects, social and behavioural and clinical aspects of the COVID-19 epidemic. It's a great privilege for me to sort of drop in and out of those meetings and hear just everybody's experience spoken on the ground. It has been very powerful, and the discussions I think have been enormously helpful. We're hearing more about those deliberations today. So just to tell you the provenance of this meeting, this is our first Global Challenges Research Fund workshop of the year. We're very grateful to our funders for that. And it's great to be working with so many familiar faces who we've worked with over the years. We've been in the past been able to meet together in person, and particularly to be working with our sister academies across the world and through the Inter-Academy Partnership. So it's wonderful to have National Academy representatives here on Zoom together, along with many of our UK fellows who are joining us today. Now, like many academies around the world, the Academy of Medical Sciences is our national UK Academy for Medical Sciences. One of its great strengths is the breadth of disciplines that are involved. And as this pandemic has shown us, we have really needed all the scientific knowledge and research knowledge we can find across such a large range of fields, from very basic biomedical science through clinical and public health science. And that's what we want to bring together, the power of that evidence in dealing with one of the greatest public health challenges we've faced in the century. So this aligns absolutely with our mission at the AMS to promote excellence, to try and influence and research and policy, to develop talented researchers, and it's great to have some of our early career researchers joining today, and also to engage with the patients and the public, which is a major part of our mission. We regard our international partnerships with national academies around the world as extraordinarily important. It's wonderful to have people speaking, both joining the meeting in the last few days, but also a really stellar lineup of plenary speakers, which you'll be hearing from first thing this morning, to talk to us about their experiences around the world. And we are undertaking a number of activities in the context of the COVID response, in the field of mental health, in the field of immunology, and bringing the best medical and health researchers around the world to make sure that their voices are heard. Today we'll be talking about the response in 8 low and middle income countries around the world and how we can build on the lessons learned, and I think critically work together in the future. And we're hearing from David Hayman also in response from the global health point of view. I'm very sorry that I was really looking forward to joining this. Like Alex has said that I can blame him, but unfortunately today's meeting clashes with the meeting of the Council of the Academy, and I'm afraid I have to return to that meeting shortly. But I do hope to be able to join some of the first discussions. But I'll be looking forward, and actually because it has been recorded, I'll be able to go back to it at some other time. So please do let us know and have us any personal reflections on this meeting. And I hope you have really great discussions today. You'll see there's plenty of time to bring together and synthesize our thoughts going forward. And we will be producing a report of the meeting. So I would like to, without further ado, just say a few thank yous. I'm incredibly grateful to Heidi Montoya, to Heidi Van Rijn, and to Rosmouth for their help in chairing the workshops over the last 3 days, and to Guy Thwaite, who will be chairing the meeting today. And of course, last but not least, to thank our fantastic team at the Academy of Medical Sciences, Alex, Abby, Vernon, and Liz, who's currently traveling, for the incredible contributions to getting this meeting off the ground. So I wish you a very successful meeting, and I'll hand over now to Guy to chair the rest of the day.
Thank you very much, Anne. Hello and welcome, everybody. I hope that you can all hear me clearly all the way from Vietnam. So my name is Guy Thwaite. I'm an infectious disease physician and clinical microbiologist, and I work at the Oxford University Clinical Research Unit in Ho Chi Minh City, and that's where I am right now. And many of you will know that Vietnam has had quite a good experience, if that's possible, with COVID, in that the total number of cases in this country is just over 330, and we haven't had any community transmission since April the 14th. But I know that there's a very varied experience indeed of COVID throughout the world, and I'm very much looking forward to hearing the experiences of everybody on this call. I think there are at least 8 countries represented, probably many more than that, but it's going to be a fascinating 3 hours, and I don't intend to speak very much at all, and I look forward to hearing from many of you either through the chat or and Alex and his team marshalling the questions in response to the talks. So I'm just going to take you gently through what we're going to be doing this afternoon, stroke this evening. So we have the first session is going to be keynote presentations. We've got 4 fantastic speakers who are going to be giving their experience of the pandemic to date. That is going to last around an hour and a half. And then we're going to go on to the sessions where we understand and reflect on the conversations that were had in the previous 3 days. Those were around the public health, the social, behavioural and the clinical responses to this pandemic. There'll be plenty of time, I hope, for discussion and reflection following those presentations. And then there'll be a quick wrap up from me, and the meeting will end. So we have lots of excitement to come, and it gives me great pleasure to introduce the first of our speakers. So this is Professor David Hayman, who will be very, very well known to many of you, Professor of Infectious Disease Epidemiology at the London School of Hygiene and Tropical Medicine, has worked all over the globe in various guises with CDC, WHO, and even a spell with the Public Health England. David, thank you very much for speaking on preparedness and response to the COVID-19 pandemic worldwide. I will leave it to the team to share your slides, and over to you, David. Thank you.
Just before you begin, David, can I ask that everybody, I forgot to mention this, could everybody speak very slowly and clearly today, just for our interpreters into Spanish and Portuguese? Thanks.
Introduction. And are you hearing me now?
Yes, can hear you now.
Yes, okay, fine. Thanks very much for the kind invitation. What I would like to do in the next few minutes is just show you that we do have enough knowledge at present to really do a lot in suppressing this virus. And this information has come from many different sources, but most importantly, what happened in the world is that despite the geopolitical tensions that are occurring, we actually have learned quite a bit because of WHO and the way that it has brought together people from around the world so that we can better understand this virus, its epidemiology, and also the ways that different countries have approached it and what seems to be working best at this time. So I think I might need help with the slides, or do I control them myself?
Over to you, David. You have control of the screen, so you can flick through them at your own pace.
Okay, wonderful. Okay, so what I'd like to do is just to talk a little bit about how we can use what we know now in good public health practice. And, you know, many of the responses have been commandeered by the political leaders of countries who at times have not listened to the public health leaders. And as public health people, we need to really make sure that our voice is heard and that we can help our political leaders understand how we can best deal with this outbreak. So I'm going to the next slide here. What we know is that there are actually 7 known human coronavirus infections. 4 of them cause seasonal colds, as you know, and the first was identified in 1967, although their emergence from animals into humans was likely much, much earlier, at a time when it didn't spread so rapidly around the globe, and during which time it may have attenuated from what it emerged as into a more habitable endemic virus in humans. And then there have been recently the 3 coronavirus outbreaks that have caused global attention: the SARS coronavirus, the MERS coronavirus, and the SARS coronavirus 2 at present. The SARS coronavirus was completely suppressed and disappeared from human populations about 6 months or 8 months after it emerged. And it's thought that it emerged from the animal kingdom, a civet cat, into a human through some interaction in a live animal market. The MERS coronavirus, however, remains with us. It emerged in the in about 2012, and it remains an endemic disease in camels. And those camels have antibody, but despite the antibody, they carry the virus in their nasal passages and periodically infect humans. But humans don't become infected from other humans. They become infected either from animals or from nosocomial transmission in hospitals where health workers and improper infection prevention and control practices facilitate transmission. And you'll remember the major outbreak in South Korea, which was due to the MERS coronavirus. 1 person entered the country and it transmitted to 7 different hospitals and caused major outbreak. And then the SARS coronavirus 2 outbreak is what we're experiencing now. And as I said, despite the geopolitical tensions in the world, we know a lot about this virus, enough to do what we need to do to stop its spread. We know how it's spread. It's spread by droplets, as you know, from a speaking, cough, or sneeze. We know the groups at risk: the elderly, those with comorbidities, and possibly some others. We know that obesity is a major factor in various serious illness, as is hypertension, cardiac disease, diabetes, and smoking as a predisposing factor. We know the transmission patterns in some instances. We believe that there's asymptomatic transmission, but it's not been quantified yet. The modelers think it might be up to 50%, but we don't yet have evidence. We know from information in Singapore that 6% of cases that they've had in various outbreaks that they've investigated are thought to have been infected from people who were pre-symptomatic 1 or 2 days before infection. And really that's the same as with other viral infections. We know that they are transmissible right before the onset of signs and symptoms. And we know that symptomatic persons for the first 7 days or maybe a little bit less can transmit infection to others. We also know, but often forget, that this transmits differently than influenza. This virus causes discrete outbreaks that then spread into the community, and these outbreaks can in many instances be contained, as you'll see as we move forward. We know that there are laboratory tests for diagnosis. There's the PCR, which is being used, and there are antibody tests which have variable sensitivities to help us understand previous history of infection in humans. We know of the importance of physical distancing, and WHO recommends that this should be greater than 1 meter. And we know the importance of hand washing, and we understand that masks can be used to protect others, but they're not protection for individuals, as we'll talk as we go through. So that's what we know in the epidemiology and intervention of SARS coronavirus 2, and these are the tools which we have. We also know that, let me see if I can move this slide. Sorry, for some reason the slides were jammed. We also know that this virus, as it occurs in discrete outbreaks, is very contagious over a long period of time. And I think many of you may have seen, sorry. And many of you may have seen this slide, which comes from an outbreak in the state of Washington in the US. Can someone help me in London? Okay, this slide shows you a person who was ill and who went to choir practice, which lasted during a 2-hour period. And in that choir, you can see that 87% of the group developed COVID-19, either confirmed or probable cases of illness after that choir practice. So we know that this virus transmits in very closed situations where there's long exposure to others. And in this case, it probably transmitted either by cough or by droplets from singing. We also know, with the next slide, I'm not able to move my screen. Yeah, okay, thank you. We also know from the next slide that this is a very lethal infection in the risk groups, who are those with comorbidity and the elderly. And as you can see, by the 8th of June, there have been 1 million deaths recorded in the world, and there will likely be more. And these deaths are occurring in those who are seriously ill, mainly comorbidities and those with the elderly. Next, please. We also understand that this virus does, like other coronaviruses, produce antibodies in the serum. And we know that the serum antibodies for the other coronaviruses that cause the common cold do provide some level of immunity, but for a short duration of time. And so after 6 months, you can be reinfected with the same coronavirus that causes the common cold. We also know that SARS coronavirus causes antibody. We know that this antibody is very difficult to detect in people who have had mild infections or mild disease or have been asymptomatic. And we know this from studies in China and from studies that are occurring now in other parts of the world, that the antibody is not a reliable test as yet to determine past illness. And therefore, The idea of having a passport that shows your immune status so you can safely go back to work and not be infected is not yet something that we can envision. Next slide. We know that we don't have vaccines and we don't have therapeutics, but we do have diagnostic tests. And those diagnostic tests are very important when you look at this list of tools which we might be able to use at one time. We know that there are various types of vaccine under development and study, over 130 different kinds. Several are in human study in China, in Europe, and in North America, but we just don't know when and whether there will be an effective vaccine. And if there is, then of course it will be the production capacity that's very important to make sure that everyone has access to this vaccine. We know there are antigen and antibody tests, and we'll talk about them later because these are the main tools that we have today to help us deal with the outbreaks that are occurring. We know that there are studies of repurposed drugs. We know that Oxford University has just shown that dexamethasone is important in treating patients, but we don't yet have any drugs which can cure infection or really prolong life as we would like to see, except possibly for the dexamethasone. And we know that there are studies of plasmapheresis, that is of antibodies from survivors, which are being studied along with monoclonal antibodies to see if any of these might modify disease if provided early in infection, such as they do for other infections such as hepatitis B or rabies. Next slide, please. Now, so how do we make sure that we can use these tools to the best of our ability in the absence of vaccines and therapeutics? Well, we need to do outbreak containment activities to suppress the virus. And many countries unfortunately abandoned this strategy when they saw the rapid increase in cases. And by abandoning that strategy and moving only to a mitigation strategy, such as influenza, they may have missed the opportunity to keep the reproductive number lower than it is even now after forced suppression by lockdowns of societies. So we know that patient diagnosis is possible with a PCR, and we know that they can be isolated successfully, but they're risk to a health personnel if there aren't protective equipment available. We know that contact tracing is effective if it's complete, and if patients are isolated for 14 days, those contacts are isolated in case they might be infected and transmitting. We know that a surge capacity and readiness of hospitals decreases mortality. So if hospitals are ready for surges, they can maintain low levels of mortality, as we've seen in many hospitals, or lower than has occurred in some other countries. And we can see that protective equipment in health facilities protects health personnel. At the same time, we know that there are personal protection measures, and these are extremely important in underlying what we're trying to do to suppress that virus. And this is physical distancing, everybody understanding that they must maintain at least 1 meter distance between themselves. And in some countries, this is actually up at 2 meters, but the WHO recommends that the evidence shows only greater than 1 meter. We know that social distancing is also important, staying away from crowded events. We know that cleaning of contaminated surfaces may contribute by cleaning up droplets that could have contaminated surfaces where people with infection were present. We know that cough etiquette, sneezing and coughing into the elbow, and hand washing are very important in preventing spread of any infection, including this one. And we know that masks are effective if we wear them to protect others when physically distancing is not possible. This means in confined spaces. We saw what happened in the choir in the state of Washington. So we need to be sure that everyone is wearing a mask properly in areas such as confined underground cars on the tube, or other areas where physical distancing is not just possible, including in elderly care homes and in our own homes if we're close to people who might be elderly and we cannot physically distance from them at all times. So these are the tools we have, and these tools are very effective, and I'll try to show you the next slide how effective they really can be. Well, not this one, but the next one. These slides, actually, these this is what happened in Hong Kong, the epidemic curve, when they applied good epidemiological principles and public health. So if we could go back to the previous slide, this is what Hong Kong has done. They've shielded populations at risk, especially the elderly and those who might be in elderly care homes, by making sure that the employees wear a mask at all times when they can't physically distance, and making sure that the patients are protected. We also know that patient detection, rapid diagnosis, and isolation with a surge capacity in PPE removes people from the population and from starting new chains of transmission that go into the community. Contact tracing and isolation for 14 days, extremely effective when there are discrete outbreaks. It prevents new chains of transmission into the community. We know that community engagement and participation in outbreak containment and personal protection are very important. We know that mitigation based on understanding of transmission patterns is important. As we see in Asian countries, we'll talk about that in a bit. They've been able to use the epidemiology of transmission to determine where to lock down, not locking down the whole sector at the same time. And an epidemiological approach to forced physical distancing, very important in the lockdowns that go on. So the next, again, back to Hong Kong. Hong Kong, no, that was right. Go back to that first one. Thank you. What you can see, back to the previous one. What you can see in this slide is that Hong Kong had some infections imported in January, in the second and third week of January. And when they understood what was going on, they immediately responded with good outbreak containment activities. They were able to keep these outbreaks from amplifying in transmission quite well, as you can see here. And then when they got into later on in the year, they began to have more imported cases, and also they had transmission within the country. And you can see those that are epidemiologically linked both to international imported cases and local cases. But they were able, through measures of suppression, able to stop this virus from continuing to amplify in transmission. And they did that by understanding where transmission was occurring or where there was a risk of transmission. And therefore, they were able to lock down those areas. And I'll give you an example of that. In the springtime, when students came back from their holidays back to university in Hong Kong and brought COVID with them, the Hong Kong government shut down all the nightclub areas where those students gathered in order to prevent transmission. They then were able to unlock them later on and not have increased transmission. And you can see that they've been able to suppress this virus through a series of measures which include identification of patients, isolating those patients and doing contact tracing and isolating those contacts, and intermittent suppression, what they call in Asia circuit breakers, a term developed in Singapore, a temporary close down and then an open up of the sector, closing it down again if it was too early to open it. So that's the way that Hong Kong has been able to maintain suppression of its virus. The next slide will show you some other experiences. What you can see here is that China had a rapid reaction and was able to decrease and suppress its outbreak, but that now they're facing a new outbreak, and this will be the history of the coronavirus as long as it's with human populations, that it will cause epidemics from time to time. And the Beijing cluster, as you know, now has 11 new confirmed cases reported on the 17th June. And since the 11th of June, there have been 154 symptomatic cases associated with a market where salmon are being sold. And for some reason, in the area where those salmon are being sold, they've been able to find the coronavirus in the environment in the market and also in some of the workers in that market. It's not thought that the coronavirus came from the salmon. It's thought that a market worker contaminated the workplace and that virus was then contaminating the salmon and other fish in the area, and people who purchased at that market became sick. Now there are circuit breaker activities in Beijing. They've closed down schools in the immediate area of this market. They've closed down all other markets which have a link to this market. And they're doing other measures to see if they can suppress this virus while at the same time shielding the elderly and those with comorbidities. Next. So what we are seeing now, and what might be the future, is we're seeing that countries have been able, with various strategies, in some it's been quite severe with complete lockdowns, in other it's been a circuit breaker approach while continuing outbreak containment activities. But whatever has been done in countries, the epidemic curve has now been flattened. And with the next slide, you'll see what we need to do to continue making this curve remain at a flattened level. We need to continue monitoring and risk assessment and response, as has been going on in Asian countries since the beginning, in order that we can suppress this virus and not have a second wave, if that virus is destined to have a second wave. Certainly what we'll see is that in countries where there have been long-term containment activities, outbreak containment activities, it will likely be easier than countries which have to establish this now after they've suppressed for the first time. Next slide. The last slide shows you that there is also importance of global solidarity, especially as we begin to see vaccines that might be effective and therapeutics that might be effective. We need to be sure that these are developed and made available to all populations. And the ACT Accelerator is the way that this could happen. This is a $9.8 billion investment by the European Commission, by many other groups around the world, in order that they can speed up development of vaccines and therapeutics and diagnostics, and at the same time, make them available to populations that need them. WHO is working with these groups to try to help develop mechanisms that will ensure access in the future. So thanks very much. I'm sorry for the difficulty with the slides. Back to you, Guy.
Wonderful. Thank you very much, David, for a fantastic overview. We're going to come to questions later on. We're going to keep going with the keynote presentations. And so the next speaker, I'm delighted to introduce Dr. Moses Alobu. He leads the African Academy of Sciences Grand Challenges Africa program. A very wide experience of implementing research in many resource-limited settings and both communicable and non-communicable diseases. So Moses, over to you. Welcome, and thank you for giving this talk.
Thank you. Thank you so much, Guy. And just checking that you can hear me okay before I proceed, Guy.
I can hear you very well. Thank you.
Okay, brilliant. So thanks very much for the invitation, the UK Academy of Medical Sciences, and also for the kind introduction, Guy. The work that I'm going to be presenting and discussing, I co-chair it with Professor Kevin Marsh here at the African Academy of Sciences under the AISA program. Okay, let me see if I can move the slide. Do I have control of the slides?
You should do, yep, Moses. You should be able to control from your end now, yeah.
Okay. Let's go back to my presentation, please. Okay. Yeah, maybe it's a technological challenge from my end because I cannot be able to move it. So please.
I can move them on for you if that's fine. It's no problem.
So just a brief mention of what the African Academy of Sciences is all about before we go to the priorities. And I've seen some fellows of the Academy on the participant list. We do have a tripartite mandate of recognizing excellence, think tank functions of which this is part of, and then of course implementing key science and technology and innovation programs. We are an academy of all sciences, so all those areas on that particular chart included. Next slide, please. So just to put some contextual issues that we have to consider if we are thinking about COVID-19 outbreak containment measures in Africa. We are quite aware of the top part of this screen, the high burden of disease, and also the epidemiological transition that the continent is at, with increasing non-communicable diseases on the continent. Of course, just about 1/5 of the population faces food insecurity. So just something to think about if you were to put across some containment measures. And then 1/4 of the population lives in extreme poverty. And then, of course, we do have the problem of climate change. What I didn't put here and connected to food insecurity was that there was a locust invasion in the last part of last year and also the beginning part of this year in most parts of Africa, therefore increasing to the food insecurity. But the other thing that probably just due to the way we communicate and most people do not know about is that 60% of Africa actually lives in rural populations. And in some countries, it can go as high as 80% of people not being in urban areas. And then, of course, we do have a high youthful demographic dividend. And just to give you an example, people above 65 years in Kenya are just 3.1% versus Italy, who would be at 22.8%. And then the other cultural differences with most part of the world is that we do not have care homes or elderly settlements. And where they are, they're in urban areas and the numbers are really low. Therefore, having what you would call the vulnerable population actually living out in the rural communities. And this could be partly an explanation of the low numbers that have been seen so far in Africa. Next slide. So just in terms of what our mandate is in terms of COVID-19 outbreak is really to support the research base, to identify the African research priorities, which I'm going to be discussing in the next few slides. And then after that, identifying where the research expertise is, preparing sites for actually doing work. And I'll be talking about our current database. And then, of course, just being that group that connects science to policy, to the public, and also community engagement. Next slide, please. So I'm going to be telling you a story. So the rest of the slides are actually a summary of this particular slide. We started out with an all-hands webinar. Convened for all the fellows of the Academy, especially those ones that had expertise in one area of science that is actually related to COVID-19. And we were lucky enough to get just about 275 scientists attending. And out of it, we put together a survey of which, again, I'll be mentioning several times as I go along, of which we really took the Glopida WHO roadmap and then integrated into it some few ideas. At the end of the assessment, there were 17 new priorities that the scientists thought should be specific for Africa, and a little bit different from what had been discussed in the February meeting that had been convened by WHO. And then eventually, we have been putting together a list of COVID-19 experts and researchers, and also groups that can be able to undertake research in clinical trials in various different areas of the, COVID-19 science that is needed. And then, of course, at the moment, we do have an open call. Next slide. So this was just a screen grab of what our survey was and, how we actually structured it. Next slide. And we really built it on the back of the 9 WHO areas that had been identified. I mean, we're all aware of this, and this particular work that was done by the Globida WHO had 42 priorities. And as I just said, there were 17 additional potential priorities from our initial webinar and consultation process. Next slide. So just to give you a feel of what those additional African priorities were, they are listed here, so I won't go through everything, but just to mention that there were some special focus areas that the scientists were concerned about. Groups like malnourished individuals, HIV, which we know has developed in one way or another in terms of getting some way forward for that, TB, and also sickle cell. Really asking the question, are we going to be seeing more pneumonia in children, for example, or more crises in sickle cell patients? And then there was, it was mentioned that there was a need for protocols for management of severe disease. There was, at that point, so this is work that was done beginning of May. At that point, there was interest in personal protective equipment approaches using local materials for the simple reason that most of the PPE was actually being imported into the continent. There were concerns about ethical review and how we can work with AVREV, which I know that has also moved forward to an extent that now it is possible to get a reference. Well, there is a reference committee where you can actually go and get a consolidated review before you approach your regulatory authority to, in a way, just speed up the work that needs to be done. I'll leave the others for now, but that just gives you a sense of some of the additional African priorities that were there. Next slide, please. So the survey results themselves. So I'm not going to go through all the 9 different areas, but I'll encourage you to actually go to the AAS website and have a look at the results that we got after we eventually closed the survey. But it is important to note that of the people who participated in the survey, 61% of them identified themselves as either postdoctoral fellows or research leaders in their own mind. And then 80% of them also identified themselves as living and working in Africa, with an additional 12% of them saying that even though they are members of an institution outside Africa, they do work on the African continent. So the way the results are shown in each of the 9 different areas, we have put a star on those particular priorities that had been added onto the WHO Globida list, so that they're a bit distinct. And if you go through the report, you actually recognize that some of the local priorities score highly, while some actually do not appear in the top 3. So again, I encourage you to just have a look at the report and see for yourself. There were 15 potential priorities that we put together from the free text that was there in this particular survey. Next slide, please. And I'm also not going to go through this, but it also just gives you a sense of other areas that the people who participated in the survey thought that we needed to just consider as we go along. So things like psychosocial issues, gender-based violence, and then models for deferred consent during emergency research, and such kind of things. So next slide, please. So eventually, we took the additional areas that we had put. So if you can imagine, the WHO paper started off with just about, I think it was 48, and then we added an additional 15 from experts seated in Africa. And then after that, from the free text of what we did, we also added a little bit more to now end up with, quite a large number of areas that needed survey. But the important thing is that we were approached by a group of UK funders, so UK CDR, and then together with the Global Health Network, we revised the survey now, including all the information that we had at this particular point in time, and conducted a second survey 7 weeks later. And this particular survey is now closed. We are now just going through both the quantitative and qualitative results, of which we intend to publish early next week. So please look out for those if you want a little bit more detail about how the current results look like. And in this one, we did add a distinction between immediate priorities and also long-term priorities. Next slide. So in terms of way forward, and again, I won't go through the list, but would like to highlight that we have been talking to various country emergency response groups within the continent, especially through the WHO and also the African Union, and continue to convene expert groups to advise, whether it's on bioethics, vaccine development, candidate therapeutics, PPE evaluation, and any other questions that we keep hearing about from groups that are implementing the outbreak control. For example, there was a tough question with political connotations connected to herbal medication, of which we had to do a policy paper, of course, working with the Africa CDC. So next slide, please. So our call is still open. I won't belabor that point. Next slide. And then our database was launched last week. It's a really interesting database with various different layers of disease burden of COVID-19, data that we get from the Africa CDC. And then we've overlaid the clinicaltrials.gov data that also tells us where the clinical research centers are and what they're doing in various different areas of research. So again, I encourage you to have a look and see what you can get out of this particular website, www.cdc.africa. And then finally, again, it's not enough to just put out priorities, but we need to start working towards, sorting out some of the different areas. So in this one, we did some work with DFID and put out a paper from one of our lead scientists, Edwin Baraza, out of Cambridge. The paper really highlighting the health and socioeconomic impacts of physical distancing for COVID-19 in Africa, and putting out some recommendations for African governments that could be important for them. So thanks again for listening to me. I'd like to stop there, and thank you for your time.
Thank you, Moses. Thank you for a very excellent and clear talk. very good to hear about the coordination efforts of science. It's absolutely essential, and it goes back to what David said about the importance of good collaboration in tackling this epidemic. Moving on to the next speaker, we have a slight change in the programme. Dr. Margaret Hamburg will speak now. Margaret is Foreign Secretary of the National Academy of Medicine in the USA and a previous commissioner of the US FDA. And she's going to give some reflections on COVID in the USA and on vaccines as well. Margaret, over to you.
Thank you very much. I assume you can hear me and see me?
Yes, we can both hear you and see you. Thank you very much, Margaret. Thank you.
Terrific. Well, I have to confess that I am not as well organized as my colleagues. I have no slides, only some notes that I put together that I hope I can read, as I'm a bit bleary-eyed over here across the ocean from you. It's still early in the US, but I'm delighted to be part of this. I see that my name says Peter Brown, if you can see that, but I'm actually Margaret Hamburg. So I wanted to just reflect slightly on our US experience, and then focus in on some vaccine-related issues, being very brief, because of course we want to reserve time for discussion. But I'm delighted to follow both David and Moses, who provided excellent overviews. And you know, what really has been striking to me in terms of responding to the topic of this workshop and thinking about what I might contribute is to just reflect a bit on the US experience, as was noted, and then I have been working on some vaccine-related issues globally, and David touched on those, but I thought I might update a bit. You know, what is clear is that obviously different countries have seen the pandemic develop at different rates and in different ways. The responses have been markedly different, but certainly no country has been untouched by this global pandemic. And I think all countries have been changed. We're now about 6 months into this unfolding global pandemic. And certainly in the United States, it has been surprising to see our response in many ways. We have been profoundly hit by this outbreak of the novel coronavirus. Certainly in terms of health and healthcare issues, we are the country with the largest number of cases, now over 2.2 million, and the largest numbers of deaths, pushing over 120,000 deaths. We have seen our hospitals overwhelmed. We have seen settings like nursing homes experience a very striking burden of disease. 40% of cases are estimated to be related to those kind of nursing care facilities, long-term care facilities, and a disproportionate impact on racial and ethnic minority populations and low-income populations, who both have more comorbidities and also have represented more of the frontline workers in terms of important essential services like stocking grocery shelves and providing sanitation services, et cetera, and also have had probably less access to important care. The economic dislocations that we've experienced have been enormous, with businesses shutting down, with large gathering events being closed, with universities and schools being shut down. The social and economic disruptions that other countries have been experienced in a dramatic way here in the US, with huge increases in unemployment shocks to our economic system that have required, quite novel economic interventions and stimulus packages to keep us going. But the long-term consequences in terms of an economic recession, lingering unemployment, declines in education and closure of schools really has been dramatic. And of course, they're the secondary effects on health that we've seen in terms of people being unable to access routine care needs, decreases in immunization, decreases in maternity care, people not getting acute care for heart attacks and strokes, and decreased screening for cancer. So we're expecting the impacts of that to be long lasting as well. And of course, other countries share these concerns, and low and middle income countries in particular, with some of these basic routine medical and healthcare needs. By any measure, the US should have been better prepared to respond to this unfolding pandemic than other countries. We're the richest country in the world with very sophisticated healthcare systems, a strong public health system, robust infrastructure for science, and a thriving biopharma industry. And we also have been preparing. The truth is, we've been making investments, really since the Clinton administration. We've been investing in R&D, investing in specific targeted programs, doing exercises. It's waned when crises have passed and other priorities have crowded in. But I think that many of us were really quite startled and, of course, dismayed by the poor response, the chaotic, dysfunctional response, if I may be so bold, that our country has demonstrated. We've come up short in a number of ways. Certainly a failure of leadership and political will from the top. There has not ever been the laying out of a national plan to address COVID-19 that identified key issues, needs and goals, did not define responsibilities and hold people and organizations accountable for progress and action. There was a lack of sustained focus on critical issues and concerns, and really inadequate communication and often conflicting messages about what needed to be done, why, and how it would be done. There was really a failure to act rapidly, I think, was very, very determinative of many things that happened later. Underutilization of lessons learned. We had the luxury of being able to watch this virus emerge in China and then march across Europe, but we really did not fully grasp what that was going to mean in our own country and begin the necessary preparations. And sadly, much of our response has not reflected the kind of evidence-driven action that we would have wanted and would have expected. So it has been a difficult and disturbing time, made more complicated by what's going on in our country now in the context of a major social mobilization around issues of systemic racism and the recognition that we are facing a set of social challenges that actually intertwine with this harsh spotlight that COVID-19 has shown on the longstanding racial and economic disparities in our country that really make certain populations so much more vulnerable to a crisis such as COVID-19, and of course to all of the economic sequelae to come. So this has been really a very, very sad and challenging moment here in the United States, and we feel a sense of camaraderie with other countries around the world in terms of what needs to be done from a public health and science perspective, though our leadership has not been quite as engaged in the global efforts as many of us would have hoped. As the world struggles to address this novel coronavirus management and control, it is clear that access to a safe and effective vaccine or multiple vaccines is absolutely essential to the path forward. As we've already been discussing, there are many ways to manage and mitigate the effects of COVID-19, but really a vaccine offers an entirely new level of protection against infection and will be vital to the opening up of our economies, our social interactions, and a return to some kind of new normal. We probably won't be the same anywhere in the world following this global pandemic. And there has been a lot going on in the vaccine domain, and I do want to just touch briefly on that. I've been working on vaccine issues for many, many years, starting as health commissioner in New York City, running immunization campaigns, but more significantly at FDA, including review of vaccine candidates in crises such as H1N1, the influenza pandemic threat in 2009, Ebola, Zika, and then on the board of Gavi and serving as chair of the joint coordinating group of CEPI, the Coalition for Epidemic Preparedness and Innovation. And it has been really a remarkable time in terms of biomedical product R&D and vaccines. David touched on some of what's going on in the therapeutic and vaccine development area, but there really has been just a huge mobilization of the scientific research community across sectors, industry, government, academia working together, and also across borders in terms of a global collaboration. And WHO has played an important coordinating role, but it goes far beyond that. And of course, this is all happening at a time when advances in science and technology have given us new tools and insights, including the genomics and structural biology, and also a lot more understanding of the human immune system in response to infection. So it's been really one of the bright spots, I think, to see this mobilization of the R&D community and also the partnership with those that need to be thinking about actual deployment and distribution. We need to be thinking about speed. We need to be thinking about scale up manufacturing and deployment. And importantly, we need to be thinking about global access to vaccines as a critical tool. There are now over 120 vaccine candidates that are in development, some, of course, more promising than others. And there are at least 10 that are now in human studies. Vaccine development is moving at historic speed. The genome was posted by Chinese scientists in early January, as I think you all probably know. And just a little over 9 weeks after that, the first vaccine went into human study. As you know, vaccines usually are done in a series of stepwise phases. Phase 1 for safety, then larger phase 2 studies looking at a broadened set of patients or study participants and continuing our understandings, and then the phase 3, which is much larger and where we really get critical information that's determinative about safety and efficacy, risks and benefits. So those first human phase 1 safety studies began very, very quickly. And as I said, there are a number of vaccine candidates that are now under study in human populations. And some of this work was able to move swiftly because of investments that had been made. The Coalition for Epidemic Preparedness and Innovation was set up actually following Ebola and the recognition of the importance of vaccine to those efforts in future pandemics, and it was charged with the mission of supporting vaccine development for pathogens of pandemic potential. And they had made investments in both MERS vaccine candidates and also novel platforms for vaccine. And so within a couple weeks of the posting of the genome, CEPI was able to be the first out of the starting gate with funding some vaccine candidates. And now a much broadened effort is underway. With respect to accelerating the process of vaccine development, there are many important things that are happening that are quite different than the usual strategy for vaccine development, which is usually a very cautious and staged effort that can last, 10 years or so, where because there's a lot of uncertainty, a lot of attrition in terms of candidates that prove not to be safe or effective and drop out, companies tend to be, very, very careful, doing one phase, studying it, deciding to move forward, manufacturing more vaccine for a larger study, et cetera. We're now compressing many of those activities, doing things that would have been done serially in parallel, animal studies going on even as the vaccine goes into human phase 1 study, sort of blurring the different phases, not putting patients or the rigor of the science at risk, but certainly putting more financial risk in terms of success or failure into the process. But the sense is that this is so important to our overall strategy to combat COVID-19 that these risks are well worth taking. And there's been some very important collaborations across governments, private sector companies, philanthropy, and global organizations to help support these efforts. And part of what is recognized is that as soon as a vaccine candidate does show real promise in terms of demonstration of safety and efficacy, we're going to need to move swiftly to make that vaccine more broadly available. And so the manufacturing, which normally would be done in this staged way, as I mentioned, and normally would not be undertaken on a marketplace kind of scale until we really knew a lot more, is already being addressed, so that we may be manufacturing vaccine that will not ultimately be approved and available, but that risk is one that everyone has agreed it's worth taking. So this is also another unusual aspect of what is underway. And the vaccine clinical trial designs are also quite innovative, with master protocols where there can be multiple different vaccine candidates being studied at the same time against one placebo arm, with some common measures and endpoints, allowing adaptive strategies as we learn more, allowing cross-vaccine comparisons. And at the end of the day, we hope that there'll be more than one vaccine candidates that make it over the finish line. We hope that there will be different vaccine strategies, vaccine approaches that are approved, because some vaccines may work better in certain populations and risk groups than others. So there are about 7 different broad categories, different kinds of vaccines, from live attenuated to recombinant viral vector, protein-based, and nucleic acid vaccines that are all under study and all advancing through the development process. And I think everybody recognizes that because of the unique importance and role of vaccines as a tool and the global nature of this disease, we really do need to be thinking about global access to the vaccines. We cannot believe that any one country can corner the market on vaccines, and that any one country can truly be secure unless we address the problem everywhere and make sure that vaccines go to priority populations around the world in an evidence, public health driven and equitable manner. And David mentioned that there have been several exciting new collaborative models that are now underway. The Access to COVID-19 Tools Accelerator, which has 3 arms: diagnostics, therapeutics, and vaccines. And in the vaccine area, there are now advanced purchase strategies being run by Gavi predominantly in order to secure vaccine and a market for vaccine. There has been very significant fundraising to support these 2 efforts, the ACT Accelerator and now COVAX as the first building block of the vaccine arm of the ACT Accelerator. And I think this will make a huge difference. I'm disappointed that actually the United States has not chosen to join in thus far and is developing its own vaccine strategies. But nonetheless, this is a very, very important model. This will make a huge difference, I think, as we move forward. The vaccine research and development activities are moving rapidly. The timeframes that are now being suggested truly would be historic. 12 to 18 months as opposed to the 10 to 15 years that's been the average. I think the most rapid vaccine development to date has been 4 years. Many are concerned about not moving too quickly. We must never abandon the rigor of the science and the ability to fully assess both safety and efficacy of the vaccines under development, but we all recognize the urgency of adding this additional and critical tool to our arsenal of strategies to manage and control COVID-19. And I am guardedly optimistic that we will be able to make a vaccine. Those of us that have worked in HIV recognize that both resources and the best minds in science don't necessarily translate into a viable vaccine because of the nature of microbes. But there's a lot of evidence that a COVID-19 vaccine will be possible. We're moving swiftly, and I hope that we will, as a scientific and medical community, be able to take great pride in the accomplishment of actually being able to produce vaccines that will make for a safer, better world, and that will also help us with new insights, understandings, and strategies for more accelerated vaccine development in the future against routine and pandemic diseases. Thank you very much.
Thank you very much, Margaret. Thank you for your candid assessment of the US response, but also it's very good to hear about the innovation that is being associated with vaccines, both in the development and testing. I think that's one thing that COVID has produced is a lot of very innovative responses, necessarily, of course. So let's move on now to our final keynote speaker. This is Dr. Chikwe Ehigwezu. He's Director General of the Nigeria Center for Disease Control. He's an infectious diseases epidemiologist with more than 20 years of experience in senior public health positions, both in Africa and Europe. Chikwe, over to you. Thank you.
Thank you, colleagues, and good morning. Sorry I'm a bit late. I had to run in from another function, and I'm speaking from another office, not mine, so trying to get used to everything. But firstly, thank you very much for the opportunity of sharing with this on this conference and some thoughts from Nigeria. And and I've titled just a few words I'll say on global solidarity in the COVID-19 response. And I'll start next. Go to the next slide. I'll start on reflecting a little bit, given the diversity of the audience, not in too much detail, but on the unique circumstances we have in Nigeria. A huge country, largest population on the continent, a federal republic, which is very important in thinking through this response and others, with 36 states and the Federal Capital Territory, and each state is fairly autonomous in its decision-making, resource allocation, response capabilities, economic capabilities, and how all of that affects planning for health security that is normally a federal responsibility, but it's definitely shared. Investments in health, budget allocation over the last few years has been below 8%. 8% is actually the max over the last few years. So, not competing demands for resources in a country that has ambitions to develop very quickly, but has many challenges around security, socioeconomic status of citizens, population density, population itself, a life expectancy of 54 years. In our last JEE score, we had a score of 46. So not great, but this outbreak has also exposed challenges around the JEE assessment and how reflected it is of reality. So I'm sure there'll be some amendments to that. And definitely we've had our own fair share of infectious disease outbreaks over the last few years, from cholera to meningitis, Lassa, monkeypox, yellow fever, and a lot of these. Yes, we've had outbreaks, but secondly, over the past 4 years, as we have improved our surveillance architecture, what we've also seen is an increased detection of outbreaks that previously might not even have been detected at all because of the investments that we've made in strengthening our surveillance capability, our lab capability, and just awareness on infectious diseases across Nigeria. Next. So that provides an important context for the response going on. But I wanted to reflect also a little bit on the Ebola outbreak in Nigeria in 2014, because it's a good comparison that we have to where we are right now. So we had that relatively small outbreak compared to other countries, but it was small because of a number of things. Firstly, we were lucky to have the index case come into Nigeria through the international airport. We mounted a very vigorous response, probably one of the highlights of public health in Nigeria, in how quickly, rapidly, and efficiently we were able to control that outbreak. And the control of that outbreak there were ultimately only 20 cases, led to really a lot of celebration and confidence. And in a way, while many other countries and contexts, the WHO and every other context did deep inquiries into why their response wasn't as effective as it maybe should have been, we kind of felt that we had a great response, and therefore probably did not do a sufficient reflection on our capabilities at the time and how to build back better into the future. Next. So we learned quite a few lessons from that response. Firstly, we didn't think hard enough about what were the lessons learned. We didn't document enough on the work that was done, and therefore probably did not learn enough lessons. Yes, we learned a few general lessons, but we weren't as determined and as specific as I think we should have been from that outbreak. There was a strong national response, a strong central coordinating response to that outbreak, which worked very well with the 2 states affected. But we never anticipated a reality that we're facing today, where we have literally outbreaks in every single state in Nigeria. And how does a central coordinating body, the Nigeria Center for Disease Control, coordinate a response in 37 semi-autonomous states in Nigeria? So huge coordination responsibilities that we were not fully prepared for. And thirdly is, the Ebola outbreak really gave birth to the Africa CDC. And unlike 4 years ago, where, collaboration across the continent was ad hoc and, very, yes, we did a good job in supporting the countries, but, we had no structures in place, no coordinating mechanism. I think that outbreak really gave birth to the Africa CDC, which I'm sure when the history of this outbreak will be told, the role they have played in coordinating lots of the response across the continent will be a significant part of the response and definitely a big part of the future of health security in Africa. Next. So down to the specific outbreak in Nigeria, then I'll pull it back into my key point for today is where are we? We have 17,000 cases at the moment. We find about plus minus 500 new cases every day. The increase has been fairly consistent, inching up fairly, not exponentially, but definitely our curve is on the up. We have about 11,000 active cases and we've had just under 500 deaths, given a case fatality ratio of about just under 3%. Next. This is Nigeria in comparison to the other African countries. Most cases on the continent have been detected in South Africa and then Egypt, Nigeria, and Ghana. And I think there are two primary things driving these numbers. Firstly, these are the countries with probably the most traffic to Western Europe. And most of the cases, initial cases in Nigeria were seeded from Western Europe, Nigeria mostly from the UK, Egypt probably mostly from France probably. And this is really indication of where a lot of the travel is, both business and tourism travel in South Africa, for instance. But it's also reflective of the testing capacity in these countries. South Africa and Egypt definitely had one of the best developed molecular diagnostic infrastructure on the continent. And because of the very complex diagnostic process required to test for this virus, it's definitely one of the factors accounting for the number of cases that they have found in those countries. And we started from a very low base in terms of our diagnostic capabilities, but now building up fairly rapidly. Next. So now from Ebola to COVID-19, what have been the changes and how have we tried to learn from those lessons? Firstly, is we've had a central coordination mechanism, a presidential task force that has provided leadership and reports almost directly to Mr. President in Nigeria, pulling in the various other sectors that are required to be proactive in this response. So we have health, aviation, internal affairs. So all the other ministries and parastatals that have a responsibility in a broader societal response. And that picture is one of the Sundays that we reported back to Mr. President. The second is, we're trying very hard to document everything we're doing and to learn lessons very quickly. Learn lessons locally, learn lessons globally, develop guidelines, adapt guidelines, translate science to policy, communicate, build an archive of our response, learn lessons. And this hasn't been easy. So we've very much integrated both documentation and both scientific documentation, but also more documentation for policymakers, for average Nigerians to understand what is going on and have been very proactive. We used to have a press briefing every single day. We've now reduced it to 2 times a week. Thirdly, we've been collaborating a lot more with regional organizations, primarily the West Africa Health Organization, but also Africa CDC, and have played a big role in distributing diagnostic reagents, collaborating on process. For instance, we lead on infection prevention and control strategies for the continent, coordinated and supported financially by the Africa CDC, while we support the rest of the countries to develop those capacities. Next. So I'll start ending. Right now, I love some of the thoughts Peggy just shared in the presentation before this, is how do we build and how do we learn the lessons and use the lessons from this outbreak in a way that we never really have in the past, even though we have always said we should learn these lessons. How can we translate the research coming out very quickly, a research that we have contributed to? We contributed the first genome out of sub-Saharan Africa to the global collection in order to support research and development going on into vaccines? How can we play, firstly, a bigger part in research, but also a bigger part in development and utility? And this really takes a lot of thinking, because we are not at the same level at our country with a lot of the capabilities needed. And we're building up very quickly. But whenever grants are written in the same process in the past, giving funds to people that have the best writing skills, they don't necessarily trickle down to us. And there is a big challenge if we want to create an equitable world into the future, both for research, development, and ultimately access to vaccines. We have to think out of the box and really be not just neutral, but almost have some affirmative action around research resources, and be focused and almost plan, listen, these are parts of the world where in our own collective interest into the future, we have to invest in the building blocks, not as a, as a charitable event, but actually being proactive around health security if we really are serious with our term, global health security. And yes, we have to do our own bit here. And we are really, I can see change happening in government around resourcing health. I think this outbreak has really brought to the light for the first time how important health and health security is, and how it can bring an entire economy to its standstill. And I do think there'll be a significant reallocation of resources into the future locally. But in order to make that work the best way and the most efficiently, we need a North-South collaboration that has never really happened effectively in the past. And that means we in the South have to devote more resources, more people, more investments, but we really need the global North to also be more proactive and deliberate in investing in institutions, systems, and capabilities, and not only as charity, like I said, but really in the best interest of everyone, because no one can solve this problem on their own. Next. So I think, and I'm rounding up, that there is an opportunity to build back better for the future, and really building partnerships in the true sense of the word partnerships, in a way that both partners benefit, both the giver and the recipient, knowing that ultimately that giver-recipient relationship might not be the relationship in the next 10, 20 years. The person receiving, the country receiving at the moment, might be in a better and should be in a stronger position a few years down the line. The role of regional organizations has never been more important. So any discussions anywhere about the value of WHO is short-sighted, and we must raise our voices to speak for the need and importance and role of regional organizations. There's no way we can each start solving our own problems independently and start working on bilateral relationships to solve our problems. We need to come together, and there's never been a time where regional and global organizations are more important than now. And we need to be able to share a lot of the lessons that we've learned now, these opportunities of conferences like this that enable access to knowledge to more people than we ever thought was possible because of technology. Really be proactive post-COVID to use this to share knowledge internationally and regionally a lot more proactively. I think that's my last slide. If you go to next. Okay, I have one more. This is really a summary of what we're doing. We know we started from a low base, so we're quickly building up our lab network, and not just building labs, but connecting them together into a hub and spoke approach. Like I say, there's a lot more political willingness to spend on healthcare, and we'll keep pushing for that. And we really want to build build back better for the future. It's not just a phrase, but something that is conscious in all the decisions that we're making, procurement decisions that we're making at the moment, investment decisions that we're making sure that we have both the short and long term in sight all the time. Next. So thank you very much for this opportunity. I'm sorry I wasn't here from the beginning, and I can't say too much into the future, but into the discussion. But I'm grateful for the opportunity of sharing a few thoughts from Nigeria, and look forward to working with you to building a better future for global health security. Thank you.
Thank you, Chikwe, for that inspirational call to action. I think there's a theme, some themes developing here around the need for strong coordination, strong collaboration, strong leadership in responding to this virus. So now is the chance that we all get to demonstrate our Zoom skills, and it all becomes interactive for a little bit of time. I'm going to pass over to Alex now, just to explain how we're going to do this question and answer session. I'd quite like to know too. Alex, over to you to explain how this is going to work. I think we've got 15 minutes for question and answers, but tell us more, Alex.
Correct. You have 15 minutes. All participants can submit questions via the Q&A function at the bottom of the screen, or alternatively, you can, I believe you can still raise your hand, and I will see you and I will allow you to talk and ask a question. So you go ahead.
So I think Alex will identify questions, but I will start if there isn't anything at the moment. I'm going to ask David a question, actually. David, you talked about the importance of really good sort of basic epidemiology, but there's been quite a lot of interest and action around novel technology and the sort of device technology to enhance contact tracing and sequence and isolation of cases. What do you think the future is for that in terms of being able to control these local outbreaks? You're muted, sorry, David.
Thanks, Guy. I'll say a few words, and I'm sure others will say as well. But in looking over these devices, and I have a good idea of what's going on because I actually am privileged to chair a group at WHO that's advising the current program. And looking over all the devices that are available, they're adding some information that's useful, but I would say they're not yet ready to really be used generally. You can't replace face-to-face contact as a contact tracer, and that's what's important, is getting communities to trust as you do the contact tracing. But these devices in the future will certainly be important, and as they work out the different problems, which include privacy and human rights in using them, I think they'll be useful. But I think maybe Chikwe and others, maybe Moses as well, would have some perspectives from developing countries where they might even be more useful than in industrialized countries.
Do you want to comment, Chikwe, and then Moses?
Yeah, so I agree with David, and you know, I think my reflections, I missed the initial conversation, but if this is around devices and tech and apps for contact tracing versus face-to-face, it's really a topic that we've reflected a bit over the past few weeks as well. And there's no doubt that this has been kind of one of a few orphan areas of public health, because everyone thinks they know how to do it and solutions are easy. It's actually very complex to do properly. And so I think there's a lot to learn. I definitely don't think any app will solve the problem. There's a city in Nigeria called Kano. So whenever people send me new apps, I always ask them to go to Kano. This is one of the most highly densely populated cities in Nigeria with very many poor people. I say, go to Kano, do a pilot, come back with your data and show me the results. And most people never came back. So there's a lot of work in, but at the same time, I do think technology provides a unique opportunity for us to move forward. But I don't think there's any magic bullet in an app that will create a perfect world for contact tracing. And we really have to find a way of bringing these two worlds together.
So, would you like to comment?
Yeah, just adding to that, we've seen a lot of innovators on the African continent coming up with these contact tracing apps that they've tried to integrate with various different laboratories. I guess the current challenge is that it's a bit difficult, and just as Chikwe said, integrating it into the current databases, you know, HMIS, that various different emergency coordinating groups are using. And therefore, because of that, it really becomes difficult to get something out of them. And I think that's what's holding people back, governments back from investing in these applications.
Thank you. So I think everyone's being very shy and not asking many questions. I've got masses of them, but I think it shouldn't just be coming from me.
We've got our first one, Guy, from
Fantastic.
Marcelo.
Good.
So I will allow Marcelo to ask it. Go ahead, Marcelo. You are able to speak now, if you unmute yourself. Marcelo, are you there? Whilst we wait for Marcelo to unmute himself, perhaps Ros, I think you have
okay.
Oh no, Marcelo, you're there. Go ahead.
Yeah,
Go ahead,
I'm
Marcelo.
here. Yeah, as I was saying, Brazil is also a federation of different states, as is the case of Nigeria. So, hi. So my question is for Chikwe, what is the real independence of each of the states to define their own way to deal with the actual pandemic from a technical and also from a budgetary point of view? This is very important to see what are the similarities between your place and how Brazil is dealing with the pandemic, because here we have a very special situation from a political point of view that we can discuss later.
Yeah,
that's my...
Yeah. So, of course, we've had some of that on TV in terms of events. But having said that, I think it's very similar. In Nigeria, some of the things, one example, for instance, is the use of antigen antibody tests that are not sufficiently validated for testing. And some states have basically insisted on making procurement decisions around that. We have been very firm in saying, listen, this is the national protocol. We will go through a process, and once we validated any of those tests, or we rely on global institutions doing that validation, we will include it into our testing algorithm. 95% of our states have agreed to that and are following, but there will always be a couple of states that insist on taking a slightly different trajectory in their own testing strategy. So we have to find a way. I can't formally say don't do it. So you have to really find ways of leveraging to enable people work together. But it's, public health has always been political, like David says, and it's not something that we can work only in the technical realm. You really have to find a way of mixing both and using whatever skills you have collectively in your institution to push efforts in a particular direction. But I think now that one thing has happened in Nigeria, because the Nigeria Center for Disease Control has actually, in our own context, been fairly well recognized by government as the technical institution with the scientific knowledge to support government in making decisions. And with that, we've actually had a fairly strong voice and visibility in our ability to advise government, and government has proactively taken our advice and refers to our guidance whenever it's making decisions. And that hasn't happened in many countries around the world that we have looked up to traditionally in the past. And I think that's a big shame. I hope we get back to that situation, because it's important for us, because if not, we start losing credibility in our own countries. And I think some of the great public health institutions in Rio are actually one of those that we've learned the most from and looked up to in terms of what a National Public Health Institute should be like.
If I can just jump in from the United States perspective, because we are 50 states, and public health actually, both legally and from a leadership point of view, is rested in our states, with the Federal Centers for Disease Control providing sort of an umbrella entity that offers both technical support and resources and guidance. But it is the states that manage most public health. And in a crisis, repeatedly we see that the states actually look to CDC much more because they want, you know, clear information, they want consistency of messaging, they want regional approaches in the context of something like a global pandemic. And so CDC becomes more critical as a national organization in a moment like this. You know, we have recognized the importance of the CDC in this response here in the United States, because the CDC has, I think, been more hindered by politics than in the past. And it has been frustrating for many states and critical organizations in those states to be making decisions without some of the kind of coordination and communication that they have come to rely on from the CDC. And as we look at our public health system here, and this may be the same in other countries, we recognize that it is a system that has been underfunded and underappreciated for many decades now. It has become increasingly fragmented, and the utilization of resources, both dollar and expertise, diluted as a result. And so I think there's a growing sense that as we move out of the COVID-19 crisis, we need to really undertake a significant review of how public health is structured, probably get rid of some of the small local county health departments, and really both modernize in terms of equipment, labs, IT, technology, et cetera, but also create a more integrated system.
Thank you. I think we have two more questions. I think firstly we have Ros from London.
Hello. So I'm fascinated by why we are seeing relatively few cases and relatively few severe cases in Africa. And yesterday in the clinical group, we heard from Uganda, which have had no deaths and no severe cases. And you've attributed it to less movement between and importation from outside. But that's also been the case in Europe and in the Americas, where one or two cases coming in have then led to really big outbreaks and epidemics. So what are your thoughts about that?
So yeah, thanks a lot. That's a question we are also grappling with. You know, firstly, I haven't quite concluded that we won't have a bad outbreak. I hope we don't. But you know, every day I look at numbers coming out of India, from Brazil, from South America. I wonder where we are on our curve, and I hope we don't get there. But there's definitely been something. So I think there are two questions. One is around incidence, and the other is around mortality. Incidence, we don't know. There are many factors that probably contribute to it in terms of populations, how people live, the lack of the relative. The demography is definitely one. The absence of care homes, the way they are traditionally found in the West. So there are probably many factors that contribute to this. In terms of mortality, you know, if it was just unique in one part of the continent, we might have asked specific questions. But you know, the fact that you're seeing fairly low death rates across the continent, even in South Africa, Ghana, much lower than in Nigeria. I think there's definitely something happening, and we will have to keep studying this to find out more. Initially, people thought it was just testing capacity. That definitely plays a role, like I said earlier, but I think there's a lot more to learn about the transmission dynamics of this virus and what has happened. And I also look at countries in Europe. I look at data from Spain versus Portugal, and I also wonder, I think there's a lot to learn still about what has led to some outbreaks having some countries having these exponential outbreaks and others being fairly spared. And I'm not convinced it's about only their public health response capability that many of the countries would like us to believe. Over.
Moses, do you want to add anything to that briefly?
Yeah, that's right. So, I mean, Chikwe touched on most of the important facts. Maybe I would just like to say in East Africa, for example, and I know it's also true in West Africa, that the model that was initially chosen was the track, trace, isolate away from the community. And especially because we closed our borders fairly early in the outbreak cycle compared to our colleagues in the north, may also have had an impact in delaying, well, essentially flatten the curve, as it were. But at the moment, we've started to see increasing numbers as the community spread now starts to, in a way, just become common in various different countries. As Chikwe said, initially there was concern around the low testing ratios per capita, but various different surveys by various epidemiologists, just going out and testing, random selected groups of people, did not show as if there was an ongoing community spread. So on the other hand, we've also not seen corresponding increases in adult pneumonia cases being reported by various different hospitals. So again, there are still quite a number of questions, as Chikwe said, that we need to answer. I'm sure at some point we are going to have more knowledge about what's happening.
Thank you, Moses. I think we've got time for perhaps two quick ones. We've got one from Jamie Montoya. If you'd like to unmute your microphone.
Yes, I'm very happy to be part of this panel, but I'd like to direct my question, if possible, to Dr. Hamburg. Based on your experience, how do you think can science academies significantly contribute to the national effort to control COVID-19?
Well, I think science academies can make an important difference because they tend to be a trusted source of credible, independent information, and also have access to a range of experts and their expertise in addressing important problems. And historically, our academy actually was created back by Abraham Lincoln at the time of the Civil War, because he recognized that he needed good science advice to make sound policy in terms of investments in various military equipment and other things. And that's the tradition of our academy, to really be an advisor to government. So we have been well positioned to be able to make a difference. And for example, right now, I'm part of a standing committee on COVID-19 at our academy that was requested, in some ways to our surprise, by the Office of Science and Technology Policy at the White House, to be able to provide rapid answers to important questions that are emerging in terms of policy. Whether it all translates into actual policy is another question, but for example, when issues about the expanding recognition that this wasn't just spread by respiratory droplet, but also a contribution from aerosol, and what did that mean for wearing masks before there was quite as much data as there is now. Our academy was able to rapidly do a review of available information and provide that. We also do longer term reports, not so useful in an acute crisis, but important before and after in terms of identifying critical needs and policy recommendations. But I do think, especially given the complexities of the tensions between politics and science and public health, that the academies can and must be a strong, independent voice that draws on the best scientific evidence to inform policy decisions. It has to be willing to stand up and speak out when policy decisions, even at the highest levels, are not reflecting the best possible science. And certainly in situations that we are experiencing in a number of countries where some of the governmental actions are confusing, inconsistent, and sometimes unscientific, then the academy voice and its expertise, I think, really is a critical adjunct.
Thank you, Margaret. Last question for this session, I think, is Dr. Ramesh from India.
Thank you so much for giving me this opportunity. I just wanted to ask you about, from all of you, as to how long is this pandemic likely to continue, considering the public health systems in the middle income, low income countries are already fragile, they're underfunded, under-resourced. How long can they sustain a pandemic of this nature if it is protracted? And it seems to be likely to go on for a long time. I mean, we are still seeing now a surge as we had unlocked after 10 weeks of a fairly rigorous lockdown. So this is a matter for concern, and several of the states in India is a large country, and several states are at different levels of effectiveness in terms of public health, and particularly human resources are unable, may not be, I'm afraid, would not be able to sustain this demand for a long time. Considering that a country like India has been more doctor-centric and hospital-centric rather than paramedical nurses. So this is my question.
So who's brought their crystal ball? David, how long have we got?
Maybe I'll take just a quick try at that. It's a very important question. And Ramesh, as you noted, nobody really knows the destiny of this virus, but we anticipate that it will be with us for quite a while. Those other 4 endemic coronaviruses also likely entered populations in the same way, maybe hundreds of years ago. We don't know for sure, but we do know that when they entered, they may also have been virulent. But over time, as they reproduce, they may have mutated in such a way as to decrease in virulence or increase in virulence or modify their transmissibility. So that might be one thing that happens. This virus is not a stable virus. It might at some point mutate into a less severe or even, unfortunately, a more severe manifestation of disease. So the destiny of the virus is not known, but we do know that countries all can begin to innovate, and India especially is innovative in how they approach different activities, and will be able to use the basic principles of epidemiology, such as contact tracing or trace and test, whatever people want to do, using the excellent diagnostic tests that are already being produced in India and could be produced in even greater quantities, with some innovation in how they can be more user-friendly, so that India can deal with this with the means that they have developed and innovated within India. So I think all countries are looking to each other to see what might be possible. But one of those is to continue to innovate in India, get those diagnostic tests out there, make sure that communities understand that they can help in helping with contact tracing, and try to interrupt outbreaks that you can interrupt, while at the same time making sure that hospitals are able to take the patients that come in. So I would just turn it back to innovation, which is what the 21st century has begun with and should continue with. And India is a leader in that, and I think we can all be confident that they will find ways of dealing with this, as will all countries. Others may have other views.
Thank you, David. I think we probably ought to move on to the next session. So thank you. I'd like to thank all of the panelists very much for fantastic talks and very interesting discussion. Please stay with us for the next part. I'm going to hand over to Alex briefly. He wants to set up the next session. Alex, over to you.
Just before we move on to the next session, just to remind everybody, and this is directed to the panelists, but to others as well, that the Q&A function will remain open, and if there is a question to you, so for example, I see one there for Guy, feel free to answer by responding directly, and everybody will see that response, and we can continue the conversation, and that will all be recorded. But I will pass on to Guy now to start the report back session.
Oh, you said there's a question for me. I don't see that, but maybe I'm Zoom illiterate. So we're going to go to the next part of the session, which is where we begin to look back on the last 3 days. Many of you will know and have taken part in discussions around public health, social and behavioural aspects of the COVID response, and lastly, the clinical response. And these were chaired by 3 people who are now going to summarise those discussions, and then after that, we're going to have again another question and answer session around what has been presented. So it's my pleasure to introduce Jamie Montoya from the Philippines, who's going to present on behalf of the Public Health Group in the discussions that occurred, I think it was on Monday. Over to you, Jamie.
Yeah. Thank you very much. I am pleased to present the output of the discussions by the Public Health Group. Can I have the next slide? I'd like to focus on some key public health strategies were presented by the discussion group. We talked about quarantine and isolation strategies, minimum infection control interventions, including non-pharmaceutical interventions, national advisory and scientific committees and task forces to inform policy, boosting capacity of healthcare institutions and healthcare workforce. This includes health facility enhancement in terms of ICU and equipment, and enhancing capacity of healthcare workers, both in terms of training as well as in number. We also talked about increasing testing capacity for diagnosis and surveillance, legislation, and interestingly, a whole of government approach, which means all agencies of government working together with a common objective consistent with the efforts to control COVID-19. And of course, at the end of the day, ready mobilization of resources with timely and adequate allocation of resources required to fund the efforts to prevent and control COVID-19. Next slide, please. For the key unanswered questions and research opportunities for public health, we talked about better understanding of transmission dynamics, evaluation of effective public health strategies for both the short term and the long term, and specific behavioral interventions, like answering questions like why certain populations have difficulty complying with policies and what strategies to do. We've also talked about clinical management, although this will be discussed in detail by the respective groups. Some mentioned interactions with other infectious diseases and COVID-19 protection and immunity. For social and economic impacts, prioritization in resource-constrained settings, questions of choosing where limited resources will go, and balancing public health and economic concerns and impact. Next slide, please. As a continuation in the area of surveillance, the choice of diagnostic tests in complex marketplaces, availability of many tests, both direct and indirect, and which to use for different purposes, such as for clinical management, or even for public health, monitoring, surveillance, and others. Early warning systems for resurgence of cases, like we have to devise ways of determining risks for resurgence of cases and predicting occurrence and gravity with changes in quarantine strategies. And of course, for the COVID-19 vaccine, effective deployment of COVID-19 vaccine and public acceptance, particularly countering negative perceptions about the utility of vaccines, and ensuring equitable and global access, vaccines being made available to all countries when and where they are needed. Next slide, please. For the challenges and barriers to public health response, we've had discussions on limited capacity of health systems to respond based on lack of infrastructure, health human resource, or financial resources, impact on other diseases, which result from shifting of resources from other diseases to COVID-19, inequitable access to health services, certain populations being more vulnerable or high risk, like the poor segment, the elderly, and others. Access to reliable data, and the role of WHO to ensure global consistency in public health responses. Many countries are dependent on policies and guidance from WHO requiring prompt and timely advice. And public uncertainty and misconceptions. Much is not known about the disease, such as lack of complete information on the natural course of the infection in the long term, and also questions on duration of protection and risk for reinfection for those who have recovered clinically. Next slide, please. For facilitators of public health response, coordinated national and local policies and actions, such as differences in policies at the national and the local level, legal frameworks, and again, the whole of government approach, and I should say whole of society approach, because this involves agencies in government working together with a common vision and aim together with the private sector. Next slide, please. For factors affecting adoption of research findings into policy, the facilitators identified were effective modeling studies, using reliable and understandable modeling studies that can help policymakers prepare and plan interventions based on predicted course of cases, advisory groups and task forces, new information systems which would allow rapid generation of statistics with easy retrieval and allows interoperability of existing information systems, and of course, political will and openness to evidence, which involves the firm commitment of government to provide the resources required for planned programs and their willingness to use the best evidence available. For the challenges, there's rapid developments in science and information, and the ability to cope of countries with the explosion of information and the ability to critically appraise such information. Funding for MICs for research, inadequate research funds available for some countries with adequate resources, but also the possibility of accessing external sources even for those who can afford who have adequate resources. And application of learnings on pandemic preparedness, the ability to institutionalize mechanisms derived from past experiences, and the memory that prevents us from making the same mistakes in the future. Next slide, please. For the strategies to promote research, open science approach, and open access to information, which involves sharing the outputs of research openly and freely with access to and among researchers, effective communication fostering trust, addressing key unanswered questions and research gaps, and timely access to reliable data. Responsive health research systems are very important, involving adaptability and flexibility of the health system to address emergency situations. Next slide, please. And for the strategies to promote the use of evidence, country-led research with international collaboration, which involves intra-regional or inter-regional cooperation, harmonization of policies regionally and globally, which allows easy collaboration among researchers, advocacy by and communication among stakeholders, science academies advocating for science and the best evidence for formulation of policies and programs, and learnings from other health programs such as HIV, understanding and recognizing that the years of planning that went into the current HIV programs may be a good example for us to follow, learnings and successes as well as failures. I would like to thank all of our wonderful panel of experts I was very much privileged to have worked with. The exchange of learnings and experiences were truly productive and interesting. And I'd like to thank most of all as well, the experienced staff that made our experience and work smooth and interesting. Thank you very much.
Thank you, Jamie. A great deal of greatly important information and highlights there, which we will get our teeth into later on. So please save your questions, and we're gonna come back to a lot of those points, I'm sure. So let's move on now to social and behavioural aspects of the pandemic response, and over to Heidi van Rooyen, who is from South Africa and who chaired this part of the discussion. Over to you, Heidi.
Yes, thank you very much, and good morning, good afternoon, good evening, everyone who's joined us. So it's my pleasure to present the slides on behalf of the Social Behavioural Group. Next slide, please. So Jamie's highlighted the key public health responses that have informed most countries' strategies towards COVID-19. And I think in thinking about it in our group, some of the key issues that we think, ways in which we think social behavioral science has helped to inform some of those responses have been as follows. I think certainly impressively across most countries, strong cases of social science data have been collected and used to inform responses. From looking at and helping governments and policymakers understand the experiences of lockdown, to looking at risk communication on risk factors, public health messaging. And certainly all of these public health responses that we talk about, we really want to make the point and a really strong reminder, all of those responses are behavioral responses at their core, whether you put your hand under a tap and keep it there for the right amount of time, whether you put on that mask, whether you appropriately distance, the ways in which you work at home, all of those require behavior, all of those require social science thinking, research, policy and programming. Also data that has been collected across many countries informing and really making the point about the social and mental health and human side and face of this pandemic. This point about non-pharmaceutical interventions or behavioral interventions might feel as though we're being just a little picky as social scientists, but I think it's really emphasizing the point we were making earlier on about sometimes in our public health approach and messaging to this pandemic, we tend to sometimes forget, we talk in quite broad terms and we sometimes forget that these are indeed all driven by behavior, underpinning their success, whether or not they are taken up, whether they are used, whether they are sustained, whether or not people adhere to them, requires behavior. They are behavioral interventions, and we really would want to ask that that remains forefront as we move forward. Next slide, please. We were encouraged by, in our reflections about some of the facilitators that we think have enabled this social behavioral response across these low and middle income countries. I think really, and Jamie's made this point, wide public support for government measures, a real sense of trust, a real sense of public, citizens, communities, people buying into the social compact, putting trust in the hands of government and policymakers to lead us through this pandemic. That's been waning over time, and I think it's something we need to be we need to be thinking about how that has waned over time, how some of those good policy interventions, that good and important messaging has been diluted, has been lost, and we need to think about how do we regain some of that trust. It's going to be a long haul, as the previous speakers have talked about. We've seen also the influence of respected community health workers and essential workers and the ways in which they have been at the forefront of this driving, managing their own personal anxieties and fears, and at the same time offering incredible support to those who need it. In countries where responses have been really impressive and notable, we do see a fairly recurrent theme, and it is about the presence of advisory groups, multidisciplinary groups informing government policy. Some of those have not always been consistent in having a healthy, and we would like to emphasize, a healthy batch of social scientists alongside epidemiologists and infectious disease specialists and virologists and vaccine specialists. We think it's that healthy multidisciplinary response that actually makes for a much more robust, nuanced, and thoughtful and sustained communication and response to this pandemic. And we're going to be needing that multidisciplinary response, particularly as we move out into these outer months and years. So strong public health messaging, as Jamie talked about, the use of media, this real sense, I think, for the first time, an excitement in many parts in Africa that actually for the first time there's a sense in which governments trust evidence, use evidence, take that evidence and use it to inform policy. And for many, where there's been a lot of skepticism around evidence, perhaps a shift and a turn into this appreciation of science in helping publics manage these issues. We've seen too creative use of communication tools, this recognition and realization that perhaps there's a limitation in the authoritarian do as I say approach to public health or to our measures. That what it actually does require perhaps is a much more subtle, nuanced thinking about who can influence, who can shape this message in a way that speaks to our different target groups. So use of musicians and other kinds of people that might be able to kind of speak and get the message across. And apps, as somebody was saying earlier on, apps for contact tracing, apps to kind of get people to get onto the vaccine when it becomes available. All of those require, again, a human being to navigate, to pick up the app and to follow through on that behavior. And so alongside these apps, we have to be thinking about what are strategies that encourage and enable use, uptake, and adoption of whatever the strategy is. And we've seen some effective decentralized responses. Next slide, please. There have been several challenges and barriers too when we consider the social behavioral response in and across countries. Next slide, please. And those have really, I think, one of the big ones in Africa with our wide and overriding inequalities that kind of shape our countries. Our countries don't all look the same. Even the US, in the way in which you look at it, there's a sense in which there's a big kind of sameness. There's a big middle class. Many parts of Africa, there's such a huge sense of this inequality. And so we've experienced some of those economic factors and the ways in which our messaging, our strategies perhaps talk to some people in our response. And we didn't give enough attention to what does it mean for some of these public health responses and strategies? What does it mean for those living in urban slums or busy townships? So really taking into account those places and ways in which a lot of those strategies may not be able to be followed through. The economic consequences of lockdown was a real challenge and barrier. Many of the lockdown challenges, and I think social and behavioral science really important in helping document what does it mean, these psychological impacts, lockdown fatigue that we're all starting to experience now, the ways in which being isolated, crammed into your home with the people you love or you like, or actually a mixture of all of those things I don't like very much, and seeing these increases in domestic violence, the impacts on families and those longer term kind of consequences. We must be thinking about how we document, tell those stories and think about policy to try and address that. I think we have to be thinking much more carefully about this. We need different and much more complex guidelines that take into account some of these rollbacks of lockdown periods. At the moment, many of us are experiencing that, and the simplicity and clarity of the messages in that first phase are not following through now in these subsequent phases. And we have to think about that. It's meant that a lot of those regulations are now open to interpretation. And with that, there's the potential for more risk and the spike of those infections. Some of the other social challenges has been a stigma linked perhaps to still lack of information, fear about this disease, fear of contagion, about who gets it, has led to some stigmatization about people who get COVID-19. And we've seen many examples of that, and that has resulted in delays in health seeking. And then this perennial challenge we're always going to be facing in this new kind of world in which we live, misinformation and fake news. And how do we kind of find ways of getting publics to distinguish between those evidence-based facts and information that is helpful and the kind of unending slew of fake news that we all have to kind of wade through. It's really critical and important because it leads to mistrust and undermines our potential to put forward really good, useful messages. Next slide, please. Some of the challenges and barriers on the policy response have been, and I think our US speaker talked a bit about some of that, and we've seen it in other countries as well in Africa. Sometimes this divergence in policy response at a central level, and then in terms of implementation on the ground, those who are responsible for implementation, not always interpreting things in the same way, not always holding things in the same way, understanding that messaging in the same way. And so a bit of a disjuncture between message perhaps from the state or that central message and then conflicting pushback from implementers at other levels. Lack of coordination in some countries has been a real problem. There's a sense in which there hasn't been a coordinated response. There hasn't been a sense of central leadership guidance. And I think all of us in all countries around the world, there's been a sense of needing that to kind of help publics, communities feel as though they can get behind that and rally and support that response. In many contexts too, real harsh implementation of lockdown rules and a real infringement of those human rights. And so lots of that good sense of trust in the beginning, a sense of we in this with you around, we are making the social impact together. As these have started to be implemented, these measures have started to be implemented, and really a sense in which these human rights infringers are starting to eat into and undermine that trust that was so strong in the beginning. In many parts of Africa, still continuing resource shortages, and the ways in which managing COVID has got to be managed alongside a shrinking national purse to deal with a whole range of other health conditions and issues. There have been evidence challenges, limited evidence in some areas around masks. It's conflicted and changed, as we know, over time. And I think for us, just a real kind of plea, and it's not just a plea for biomedics out there, but it's also a kind of a challenge to ourselves as social scientists, is to kind of find a way of being much more visible. There has been visibility in our social science and behavioral messaging strategies and work, but we really have to think about how do we kind of influence and shape and bring in the social science much more purposefully into this response. Understandably, the response in the beginning has been around the virus, around natural history, around diagnosis, as our colleague from the African Academy of Science talked about. But that social science and behavioral response must be there from the beginning, infusing all of those things, and certainly must take prominence and center stage now as we are all thinking about how do we live, how do we manage, what are the consequences, what are the impacts and sequelae of this pandemic as it unfolds. Next slide, please. So several factors have affected adoption into policy, and I think we're really excited about those and really want to see and encourage a continuation of these existing multidisciplinary advisory bodies. Political and public engagement by social scientists, a sense in which we have been visible, we have been trying to mount up our response and make our contributions felt and heard, and that we would like to see reciprocated and in greater involvement in some of these think tanks supporting government. But I think the challenge to us also is that we have to be thinking about and better about the ways in which we do things. There's a way in which sometimes as social and behavioral science, we are slow in our response. We are careful. We want to kind of do things in a much more thoughtful and deliberate way. And sometimes crises and pandemics can't wait for us. And we have to find ways of innovating, of using rapid evidence reviews and syntheses, quick ways of going into countries and into communities and finding that evidence that will inform and shift and shape policy and turn that into useful programs and interventions for people. And we've seen that again. There have been some innovations and quick online surveys that have been using that information to try and shape policy. The point was made earlier on, I think, by the speakers, and this point about as we enjoy as science, perhaps a recognition of our contribution in this response in the pandemic. I think just a reminder always that as we do this, as our work has been used to inform and shape policy, we also have to be mindful of our objectivity, of our need to remain independent, to keep our voice is really important as we move forward with this work. Next slide, please. Our last two slides, we've got 3 more slides, and our last 2 slides just kind of talk about possible priority areas for research. And I think much of the initial research surge has been about thinking about biomedical and clinical responses to this. And I think necessary and understandable, that's the long haul, that's what we're all waiting for as the intervention that's going to kind of help us in fundamentally respond to this pandemic. But we think there's lots in between that. There's a lot now and a lot alongside that very strong biomedical response around vaccines development that we heard about earlier on that needs to happen from a social science and behavioral perspective. The impacts of this are unknown on young children, and adolescents and unborn children. The mental health implications are also beginning to be seen, but again, unknown, and we need to be documenting that and thinking about how do we best support some of those interventions. We need more on what of those measures are most effective from a behavioral point of view, as one of the other speakers also said. We need to understand impacts on health-seeking behaviors and how this affects not just taking up and addressing COVID-19, but how this might affect your HIV and your TB and your obesity and your other health-related conditions, because we know that this pandemic is going to, in a very deepening kind of way, worsen some of those conditions. So how do we kind of find ways of encouraging people to manage COVID alongside managing other conditions, seeking help? We need to understand more about substance abuse behavior and how this might be impacted in the epidemic. And I think importantly, we're moving into a stage now where we understand this pandemic doesn't affect everyone in the same way. There's a gradation of target groups of populations, some who are healthy and less at risk, and those who most definitely are at risk. There's variations and a difference in terms of age and a whole range of other factors. And so we begin to need to understand again that difference and that differentiation and develop appropriate policy and programming for that addresses different ages, demographies, and social groups. Lockdown and learning about lockdown. And I think we can all understand this question so intimately and so personally now, given the way in which we're all forced to live and live our lives. And so from a personal point of view, this learning about lockdown, how we effectively managed these lockdown rollbacks, and what have been some of the drawdowns of some of these really, really strict lockdowns. What are the benefits? What are the drawbacks? What have we learned? How do we take that forward? Next slide, please. Some possible priority areas for research. We think at this point of contextualizing responses to different settings, populations, and health contexts, how to integrate COVID-19 and other health needs. We've been, as I said, one of the really strong and heartening things has been this kind of community response, the ways in which communities have shown resilience and worked with each other and innovated with other NGOs and other groups to kind of find appropriate ways of dealing with and responding to this. We think there's a real strength in that, and that must be used more in our response as we move forward. So what can we do about and think about and use community adaptation mechanisms and resilience? Pandemic anxiety, understanding that more, how that impacts individually, how it impacts us as a whole society, as a globe, this pandemic that has really affected us all. And understanding more about how we transition into the new normal and the adaptations we have to make in our lives. More on communication and behavioral messaging. And certainly I think for many of us in Africa, this is a really, really important point, this understanding of these social determinants of health, our age, our race, our class, who we are, where we live, and how those impact on health behaviors. We have to understand that more. We have to understand in these contexts of discrimination and trauma, how receiving, having been infected by COVID-19 adds to that, makes that worse, deepens that, really impacts that health trajectory for that person. So we have to understand these deepening impacts of COVID on marginalized and indigenous populations. And our last slide is really just a kind of a call to, I suppose, to all of you gathered here today, biomedical science. There've been many impassioned calls that have been made, but I think COVID might give us opportunities to do many wonderful things together. And perhaps one of those, alongside the interesting and wonderful ways in which we've seen people coming together around the vaccines, might also be for the first time recognizing the central role that social and behavioral science must and should play in this epidemic. We often are the kind of stepsister, the ugly stepsister in most responses, coming on at the end of something when things are failing, when biomedical science is not working, people are not taking up these wonderful interventions. And perhaps COVID brings to us this challenge of finding ways through our multidisciplinary and international collaborations to be much more deeply integrated with each other in thinking about our response. We think we need to be more innovative in our strategies. We have to be rapid in our methodologies and also in our dissemination. And we must think about being science and medical academies, your role in helping us to convene, to promote interdisciplinary and comparative work, and really using this first step as a way of taking us forward together. So thank you very much.
Thank you, Heidi, for that beautiful summary. Two things struck me, I think, especially as I'm a biomedical researcher, that's the importance of behavior in virtually every single intervention that we have for this, this infection. Secondly, the importance of multidisciplinarity. So thank you for reminding us of that. We go now to the clinical section, and it's Professor Rosalind Smith from London who's going to present the summary from the clinical group. Over to you, Ros.
So good afternoon, everybody, and it's a real pleasure to present on behalf of this very dynamic and interesting group that we had yesterday. So as has already been alluded to, countries are at a very different stage of this trajectory. Some have not really experienced many cases and no severe cases, and others are really very much in the thick of it and struggling in many instances to cope. So some are in a position of learning by doing and others learning by watching. And in many centres and countries, people are moving from the emergency phase to, I think, what we've alluded to as having to live with this coronavirus. And working in that very dynamic and changing environment has been a challenge, but many have risen to it very well. So next slide, please. So in terms of the learning by doing, this is some of the challenges and successes that were shared and grouped under preparedness. So getting the ICU capacity up to speed, some challenges, for example, in countries with public and private healthcare systems. The public healthcare systems are overwhelmed and the private healthcare systems are empty. So trying to get that coordination between the two. Suspending routine clinical care, which we've been able to do in many centres on a short-term basis, but of course, as we realise that this is going to continue for some time, then that suspension cannot be sustainable in the longer term. We heard from groups who've gone out and tested in vulnerable areas, in shantytowns and slums. Other community-based approaches are virtual hospitals where people who've got symptoms and are unwell can be monitored remotely and brought into hospital when needed. And then there's been a lot of different approaches to quarantining, ranging from hospitalizing all patients who are positive, having hotel facilities for patients who are positive, to being unable to do that sort of community quarantining. Various protocols have been developed for patient pathways. Risk stratification has been important. We heard about this phenomenon, patient self-inflicted lung injury, which is a very different presentation and phenotype to people with ARDS and needs to be managed very differently. So having that personalized approach, developing algorithms to address how we should manage patients, for example, with anticoagulants. And then integrating all of that into guidelines quickly and effectively. And we've heard some very positive stories about how clinical trials can be run very successfully, even in hard-pressed and very busy environments. So next slide. These are some of the important practices that have been implemented, looking at oxygen therapy, particularly high flow, different ventilation modalities, depending on the presentation, as I've mentioned earlier. The dexamethasone study was announced yesterday or Tuesday, and that's going to have a big impact worldwide. Prone positioning seems to have been implemented very rapidly following the initial reports. And then managing the cytokine storm, managing other comorbidities in the patients. And we had lots of discussion about anticoagulation, which patients, when it should be initiated, which agent should be used, what dose, for how long, and so on. Still lots of questions not yet answered. And managing antiviral therapy and chloroquine was discussed, and convalescent plasma, and particularly from Argentina, experience of Argentine hemorrhagic fever was very relevant to implementing those sorts of measures in that particular country. Next slide. So how did we do it? Well, I've talked about learning from relevant previous experience, and I think in those countries who had experienced the SARS epidemic, that was extremely useful in contact tracing and isolation, local expert opinion, and clinical trials. Next slide. So we then talked about the gaps, and I provided an additional technological challenge to my group by asking them to vote. So we've got two slides on the gaps. So all of these gaps were thought to be important, and we discussed them all. But those on this slide that were most important were the questions around anticoagulation, as I've already mentioned, immunomodulators, which agents to use, when to use them, how to monitor patients. A very important question in how, particularly in resource limited settings, we distinguish on an X-ray between pneumonia from pulmonary infarction. Now, it's not possible to do that on X-ray, but what other imaging modalities may help us discern that and decide how, therefore, to treat the patients. And then the other gaps in the evidence, I'll let you read on the slide. Next slide. So the two top ticket items here were in those patients who develop antibodies, what protection does that afford? How long does it last? We don't have the answers yet, but it's important that we gather that evidence and provide it. And then how we triage patients who are in the community to identify high-risk patients, both for admission to hospital and then when they're in hospital, identifying those patients who may need intensive therapy. The other issues, genetic predisposition to poor outcomes is important, and those studies are being done. There's a study today in the New England Journal of Medicine. And again, in terms of delivery of care, how we look after these patients effectively whilst at the same time delivering other essential care, including preventative care, screening, childhood immunizations, and so on. Next slide. So what has worked to enable that care to be delivered effectively? So mentorship, managing the information tsunami. This sort of discussion that we've been having with webinars and discussion sessions was considered very important. Innovation and clinicians being up for new ideas and ways of delivering care, such as the virtual hospitals that have been established in some centres in the UK, and innovative approaches to mobilising all available resources, including the private sector. Next slide. So this slide addresses how we might effectively roll out multi-centre international research studies to address some of these very important questions. So global networks such as are assembled here today are very important, and I think the different academies have played a very pivotal role in that. We need to expedite research approval processes. We need to expedite funding calls, and many of us have participated in that. It was felt that the regulatory environment needs to step up and be able to turn things around rapidly and effectively in response to that. And considering the international sites whenever one's developing a protocol for clinical studies and what the particular situation is in those different settings, and having clinical trial designs that are innovative and can adapt to those different settings. So my final slide is to thank the wonderful group who came together, and I see many of their names here today. We had a very lively discussion, and I think it's been very useful. Thank you.
Thanks, Ros. That's a great summary. I think it's been an extraordinary time to be doing clinical medicine over the last 4 months. And I guess we're in this really exciting phase at the moment where we're at the start of kind of evidence-based COVID care, with the results of trials now becoming available. We're now at the point where we open up for discussion. So the same principles apply as for the first session. Please make your questions available via the chat box, and Alex will pick them up. And apparently we already have a couple of questions to chat ready. So Alex, can you highlight them, please? I'm struggling with multitasking here.
No, that's right. So Dr. Awang from Malaysia had a question. Hang on, let me see if I can. I think we might have lost her, in fact. Nope, there we go. There we go. I've allowed you to talk, so you can ask your question.
Okay. All right. Can you hear me now?
Yes.
Okay. I was just wondering, because this is something that we have not studied. We thought about it, but we didn't have time to do it. Lockdowns, especially when lockdowns are very restrictive, for example, has there been any evidence there's been increased feelings of social isolation, especially among the elderly? Because we do know that depression among the elderly can lead to consequently physical illness even. And I don't know whether anyone has recognized this.
Heidi, do you want to have a first go at that question?
Yeah, sure. Well, I don't know the answer to it. I don't know, but I think it certainly is one of those things we have to be looking at, as I was saying earlier on. I mean, I think the lockdown has impacted in various ways. Certainly we know from a mental health point of view, those with pre-existing depression, anxiety, one would imagine, and certainly there's evidence around this, that this increased lockdown, we've seen an impact on some of those prior conditions. And so I would imagine for those, for the elderly, for example, I think that we don't know what the impact is, but I think it is a necessary and important piece of work that we should be doing to try and document and trying to understand and think about how better to intervene. My sense is it's also very different, just depending on different personalities. I mean, just in thinking about some of my colleagues and how we're trying to manage remote work, and there are those who are more introverted who are finding some of this finding lockdown actually invigorating and wonderful. There are others who are needing the social contact, who kind of work by that bounce of ideas that you have with other people around you, who are finding actually lockdown quite isolating and quite limiting and quite restrictive in many ways. So I think we don't know the answer to this. I think it's a really important piece of work just across the board, including the population that you mentioned.
Thanks, Heidi. Ros, do you want to give a clinical perspective on that problem?
So this isn't something that we discussed at all, social isolation in the elderly. It was more the clinical management of the elderly when they came into hospital.
Okay, thank you. We have another question, I think, Alex?
Yes. Marita and Adiba, you both got your hands raised. Let me know if you wanted to respond to that point specifically. Otherwise, I'll move on to a new question. I think in the meantime, Helen had a question that she raised earlier, so I will allow her. There you go, Helen. You should be able to ask the question now, or make the point.
Thank you. I wondered whether I could ask the clinical and public health colleagues to pick up on the point that was raised in the feedback on the need for social and behavioural sciences to be fed into the design of public health measures to make them workable, not just as was framed in the way the invitation was framed, into the adherence to these measures. I just mentioned the behaviour as part of all of these responses, but there's clearly a need for social science and behavioural science understanding and knowledge to feed into the development and decision-making around, for example, imposing social distancing measures in crowded informal settlements, rather than for social scientists just to be coming in afterwards to document non-adherence to that.
Yeah.
Heidi, do you want to address that first?
Yeah, no, I think Helen makes that point really well. Sorry, I've just done something really weird here, but I'm hoping you can still hear me. Yeah, I think yes, that often is the case, the sense that social and behavioral science is brought on at the end when we are struggling to get people to take something up. And there's a real value, I think, in thinking about ways in which we can get people, our potential target groups, the recipients of these interventions, to be involved with us at the startup as we're thinking about designing whatever that intervention is, whether that is thinking about contact tracing or the use of masks or social distancing, and to hear from those groups and themselves about how could we, what would be the best ways, what would work to kind of encourage use and uptake in your population, in your group. And we know that it might be different for young people. We might need different messaging. We might need different approaches in getting that intervention to work for young people as it might need to work for the elderly. But I think often we miss that. We have a one-size approach that fits all. We think this is the thing that is going to work. The science says go for it and do it. We put it out there, and then we are surprised when people don't always use it consistently. And then it's, can you help us think about how we get people to be better, to adhere better? And I think Helen makes the point well. I think thinking about and infusing some of that social science and behavioral science in the beginning, at the start of these, might serve us a whole lot better.
Thanks, Heidi. Jamie, from the point of view of public health, could you give us perspective on how we might be better at integrating social science and behavioral science into our response?
Yes. You know, it's a very difficult question. And even in the Philippines, we've been tackling the problem and finding ways. A very good example is, you know, we've been very active in health promotion, what they're supposed to do, what they're not supposed to do. Doesn't seem to work, particularly for people in the rural communities and even in the slum areas. And I think the problem here is, and I've been struck by some of the people who we've heard comments and why is it not working? Some people are saying, what is more important? Is it health or the ability to earn or to survive? Because of the social isolation and distancing strategies, they've been prevented from working. And of course, they lose their source of livelihood. So it's a question of between survival and, you know, going with the crowd and looking for work. So that's a big problem. I really think that communication strategies would be very essential here. And I think that's to be targeted. You have to put yourself into the shoes of the audience. What are their more important priorities, and sort of relate to that priority so that it gives an impact in their mind. It's very difficult to do, but we really need to work with social scientists. It doesn't mean that we're not working with scientists. Of course, we've been working with them, but it has been a difficult process. And even among our social scientists, has been difficult. We have to do and learn. That's what we're doing now.
Thank you, Jamie. Helen, could I just see whether what you think, how we could do, how could we do this better into the future? What's your view? Oh, you've been silenced, perhaps.
Can you hear me now?
Yes, we can. Yes.
Okay, I've been unsilenced. Thank you. I think there's clearly a need to, as Jamie said, is obviously happening in the Philippines. There's been a lot of talk about the need for evidence-based intervention and for the science, but I think there's still a tendency for policymakers and governments and people implementing strategy to revert to thinking that what the science means is science is quantitative. So, for example, we see policy being very strongly influenced by modeling as an approach to trying to grapple with trajectories. But there are ways in which most social scientists would easily have been able to predict the kinds of emerging inequalities we see. So I think it's a matter of bringing social and behavioral sciences in kind of at the table, as Heidi said, at a very early stage in the initial development of strategies, and thinking through all of the potential implications for imposing public health measures at the beginning, rather than seeing them purely as looking at the reactions to those. I appreciate that's a difficult thing and perhaps doesn't fully answer the question, but I think there is an enthusiasm there. Everybody understands the importance of this right now.
Yeah, thanks, Helen. Rose, did I see you wanting to make a comment too?
Just to reassure the behavioural and social science group that this was very much part of the thinking of the clinical group, that we would absolutely want to include social sciences. And there was discussion about psychological impact on the families of patients being on ICU. and reference to mental health and suicide increase as a sort of indirect consequence of COVID.
Yeah.
Thanks. Alex, have you identified further questions?
I think Marita wanted to make a point from Argentina, so I'll just allow her to talk. Marita, if you unmute yourself, then you should be able to contribute.
Okay. Do you hear me?
Yep.
Yes, we can hear you. Yeah, go ahead.
Just to say that, yes, regarding the psychological impact and the complications on mental health, there is data on public opinion. I've been personally working in Argentina together with a university, and we were looking at how people felt nowadays, say taking questions on how do you feel on the last 7 days and in the last 30 days. And we find that there is a lot of growth in sleeping disorders, appetite affected, depression, anxiety, comparing with same questions in other moments. So there is a lot of public opinion polling done regarding this, and I could very easily put you in contact with data banks where you can find this type of information for different countries and internationally. Because the psychology is really very, very, very important, and it's very high. So this should be taken very specially into consideration, and also in all advisory committees, we should have psychiatrists, in my opinion.
Thank you, Marita. Thank you. Alex, are there additional questions?
Yeah, there's quite a few questions or points about how the academies can work together in the future, and just to let you all know that those have been noted down by us, and we will look and see how we will be able to take that forward from an academies perspective, particularly with the potentially with the inter-academy partnership. In terms of other questions, I think Adiba would like to make a point. You should be able to go ahead now, Adiba.
Okay, hi. One area we've not heard much discussion about is the role of intra-hospital transmission as a source of ongoing local community transmissions, with healthcare workers going in and out and transmitting infections either to the community or to nursing homes, etc. It would appear to me that in countries like China, Italy, and the UK, where prevalence of healthcare worker infection has been reported to be high, breaking that chain of transmissions seems to be a lot more of a challenge. This is more of a comment. I guess a question I'd like to hear what others think as well, but perhaps more attention needs to be given to ensure low rates of nosocomial transmission, particularly to healthcare workers, as a key public health strategy for countries still seeing an increase in infection rates. Your thoughts, please.
Thank you, Adiba. Let's start with Jamie. Do you want to give some thoughts on that?
Yeah, that's really a problem, and it's not unusual to hear, at least sharing my experience in the Philippines, for hospitals or clinics to close down because half of their healthcare workers have turned out to be positive. And it again boils down to the fact that what will be the best measure to determine who is actually infected or potentially infected. There is an effort to actually do rapid testing for the healthcare workers, to do the confirmatory tests like the RT-PCR. But of course, you all know that there's a dearth and a scarcity of RT-PCRs, even for those who would require them, symptomatic cases, much more to look at healthcare workers. But it's only recently that there was a shift to include healthcare workers in the initial diagnostics in order to determine the risk for infection. And now we're seeing more and more healthcare workers. And I think the strategy here is really to identify the risks involved and to provide them the necessary personal protective equipment. I have to admit that some of the healthcare workers do not know how to use the protective equipment. I mean, they haven't been using it based on the recommendation, and sometimes it's based on error that get exposed to patients. But then again, we have to understand they're the frontliners, and they really have to be afforded the appropriate diagnostics and support, because without them, the healthcare system would collapse. And that's something that we should appreciate. And maybe I get some inputs on how to better implement this, but we still see healthcare workers getting infected in the healthcare setting in the Philippines.
Thank you, Jamie. Rose, do you have anything to add?
Just to say that there's some really important data being published now looking at molecular studies, looking at transmission and being able to identify quite precisely which patients led to several other healthcare workers and other patients becoming infected, and therefore what the critical points might have been in that nosocomial transmission. And I think one hospital in central London, 45% of their workers who have been exposed to COVID are antibody positives. So it's a very, very big issue.
Heidi, do you want to add anything?
Yeah, no, I'm thinking more about the kind of psychosocial consequences for this group, which I think we don't spend enough time thinking about. I think about the way in which they navigate these two spaces, right? In this really at the front line, providing these essential services, and then having to navigate ways in which in those spaces, they might be bringing infection, they might be the cause of infection, particularly when you see spikes in a hospital. And how do they deal with that? And then also this navigating this risk they take home every day to their own families. And you hear many ways in which they are trying to mitigate that. Some stay in separate rooms, some drop all the, all those measures as you enter your home. You strip yourself of work so that you can be safe for your family. And I think there's a whole range of ways in which healthcare workers, the impacts on them as they navigate these two worlds and this really very particular kind of space that they inhabit that we don't understand. We need to better understand. And I do think, I'm thinking now about some of those mental health consequences for this group in particular.
Thank you. Alex, do we have any other questions?
I think Priscilla had a couple of points that she wanted to raise, so I will just allow her to talk. Go ahead, Priscilla, unmute yourself and you can contribute.
Hello, thank you, Ellen. There are points that have gone by, but elderly, I was thinking that there might be a need to do rapid research on intergenerational issues and intergenerational stories, because in many families, that whole sector of the community is going to be wiped out. You hear stories where both grandparents have passed in a very quick way, literally grabbed away from families. So the area of intergenerational research hasn't been very strong in behavioral sciences, and maybe COVID has put in a plug for that. And in addition to that, to look at how in our kind of context, where there's a massive youth dividend and massive youth unemployment, how we can bring the two together in a way where we deal with asymptomatic transmission concurrently. And that's a whole family context that we would need to talk about and do research in, both from a determinants perspective and from an actual behavioral perspective.
Heidi, do you want to respond?
No, just, yeah, absolutely agree, Priscilla.
Jamie or Ross, do you want to respond to that?
Well, just to say as a paediatrician, that the impact on children who themselves may not experience a high burden of disease as a result of the infection, but the impact of school closure and bit of the family being locked down and the rise in domestic abuse. I mean, I think this is going to be with us for a long time.
Yeah.
And we've had families, because in the Philippines, closely knit families, the elderly people stay with the younger members of the family for psychological support, for, other reasons. We've heard stories, of course, of grandparents, as I mentioned, intergenerational losses. grandparents and parents both being afflicted with COVID and eventually passing away. And this has actually dealt a big blow to especially the young families, because we are, Philippines is predominantly a young population, and you've basically removed the support that the young people would like to have from the older people. And I'm sure we need to see this impact on the long term as we recover from this pandemic.
Yeah.
Thank you. Alex, I'm conscious of the time. Do we have time for one more question?
No, I was going to say that I think all the points and questions that have been raised, we will obviously capture these and reflect these in the final report and add them to what has been presented already. And as we said in the first slide, if anybody has any additional points that they would like to raise, including people on the live stream who didn't have an opportunity to participate in the discussions, they can send them through to the email address that was on that slide, and we'll show that at the end of this session as well. I think we can go on to the wrap up now, Guy.
Okay, thanks, Alex. Well, thank you everybody for your contributions. It's been an incredibly interesting 3 hours. Very difficult to summarize the complexity of what we've heard and to pick out the really important bits. But I think there are 3 things that struck me listening to the talks and the comments. And that's the value, firstly, of collaboration. I mean, this is almost trite to say this, but this is the collaboration between disciplines. We've heard about very recently about the importance of multidisciplinarity, but it's also the collaboration between not just scientists, but countries, regions, and just the essentialness of being able to work together to tackle this epidemic. So that's the first thing. I think the second thing that is, again, a recurring theme is the value and importance of innovation. I mean, we are sitting in front of a Zoom screen that 6 months ago we almost certainly would not have even heard of. And so this is one minor, if you like, innovation in our lives that we can have this type of meeting. But it's prompted a huge range of different innovative responses and innovative approaches to being able to address this epidemic. We heard from Margaret about the innovative ways of addressing and producing vaccines and testing them, and how that's being sped through in ways that previously would have been thought impossible. So innovation being particularly important. But lastly, it seems that leadership is absolutely essential in this. We've heard about the consequences of neglectful political leadership, for example, in certain countries. But the leadership also comes down to ourselves and our ability to make the point that collaboration, for example, between disciplines is enormously important, and that is a responsibility that we all bear, really, to be able to respond to this virus. So I would leave with those 3 things: collaboration, innovation, and leadership as being absolutely essential in what is going to be a very, very long and drawn out process, I'm sure, but one we will get better at. And as I referred to in the clinical section, I think it's heartening to see evidence now becoming available to tell us, for example, how best to treat these patients when they occur. So I think that's all I would say as to summarize this huge topic. I would, of course, thank the organizers, particularly Abby, Fern, and Alex, for all of the hard work in getting this together. We've had a number of calls over the weeks, and I've greatly enjoyed doing this. So thank you, everyone at the Academy, for your work in producing this these last 4 days, and all of the things that have come from it. And lastly, I think in the background there's Ian, who will be doing a huge amount of work on trying to collate all of this into a readable report. So thank you, Ian, wherever you are in the ether.